Dear colleagues, it's my pleasure to be here in the 8th annual scientific conference of radiology department of Ain Shams University in the session for body intervention. And actually the interventional radiology in the Ain Shams University is one of the most oldest interventional radiology department in the area, Arab area. And actually this department was a pioneering department in the field of the interventional radiology, and we introduced many of the recent techniques of interventional radiology, including angioplasty, including chemoembolization, radiofrequency, embolizations, drainage, and nephrostomies, and many other techniques. And actually, I was maybe honored to be one of the oldest doctor who started this technique maybe many years ago. And I was honored to have with me a very good team, actually Dr. Professor Sameh Abu Wahab, Professor Usama Hetta, Professor Khalid Shahata, Professor Hussam Fahmi, Professor Mohamad Shakir, Mohamad Ghaib, Ayman Ibrahim, many other professors who started to introduce the interventional radiology in our university, and actually in all Egypt. We was the pioneer in many fields of interventional radiology. Nowadays, I know that there is a very good expansion of this field in our university, and we have now a very well-equipped department, and the most important thing, we have many doctors, many professors, many residents who are very expert in this field, and we have to thank Dr. Sameh Abdul Wahab and the other colleagues who give a very good effort to reach to this surface, to this very international level nowadays. The first talk today will be in the artificial intelligence in interventional radiology by Dr. Mohamad Karam Mansour. Dr. Mohamad.
Good afternoon, my dear professors and colleagues. Our talk are artificial intelligence in interventional radiology. The AI started since the Second World War, and started evolving over time to reaching the picture we know now. It has two types, machine learning and deep learning. Machine learning is the old type of artificial intelligence. It's mainly less complex, no extraction of data. It mainly depends on the physician or the person who uses the system, extracts the data, and the system classifies only the data and makes the output. The deep learning is extremely different. It starts by input nodes, and deep nodes interconnected with each other like the human neural cells. Then the output is come. The role in artificial intelligence in the interventional radiology depend mainly on pre-procedure, post-procedure, and intra-procedure. The pre-procedure mainly, it can schedule patients their labs and scheduling patient appointment. Also there are responders or not responders. This depends mainly on radiomics and radiogenomics, and we'll talk about this in the next slide. And also include planning, training, and patient education. The radiomics is actual extraction of data from the medical images and analyze it through multiple advanced feature analysis. This could, like you have a system and you have a new patient. You bring the patient images, import it to the system, and the system will tell you this patient would be a responder to a treatment or not. A recent study found that the HCC in radiomics could be predictive for treatment of TACE with accuracy 80%. The upgrade of radiomics is radiogenomics. This actually is still evolving, and few researches are about it. It combined the radiomics with the genetics of the specimen to make predictive value. New researches are on TACE and TARE regarding the CRIS mutation, and also there are about RCC, yet no available data in the literature, but it's coming in a few years. The augmented reality and the virtual reality. A lot of them are under research, but we have 4 that are about talk about in this lecture. 360-degree gyroscopic camera are used for training. The camera we see. This camera on top of the main operator are recording in 360 degree, and then the video is imported on the mobile phone or any other machine. With using this lens, the trainer can see the operation as he is attending with all direction, and can see the main operator hands, the screen, the patient, everything. This is a merge cube. A merge cube is a commercially available tool that used to make a 3D object to be seen by either a lens or using a camera of the mobile. You can use it for planning and patient education. As we can see, it can project the 3D images through the phone lens. It would be helpful for the physician to convince the patient about their disease, he can see his tumor, he can see how he will go through his body. It's more convincible for the patient. And the interprocedural AI, mainly DSA creation and smart assistant and augmented reality. The DSA creation are used to avoid the small movement done by the patient, which need to repeat the DSA. As you can see, this is the original DSA. Small movement makes the pictures a little lazy. The unit actually used by Philips and Siemens. And Siemens since 2012, this is the new technique that's used to decrease the haze and the movement of the patient. Actually, the respiratory movement cannot be avoided. Smart assistant are usually used for radiation exposure, including autocollimation. A research claimed it can decrease the exposure of the patient by 37%. DSA generation we have talked about, and eye tracking. As a machine only work or open screen when you only look for the screen, like you are reading on Samsung tab. The tool availability in unit store, you don't need call for Ayman or Ms. Zainab to ask about specific equipment. You will ask the AI and it will answer you. Individualization suggestion of plans, mainly trajectory assistance, EMBO assistance, and stent stimulation. This is a needle trajectory assistance. This research made in 2014 claimed that he can use the ultrasound with gyroscope in the right hand of the male operator to guide the trajectory of the needle. This is mainly depend on how much your hand away from the probe, and then you go through this trajectory. The research claims it's only a 1 millimeter error that could be claimed through this model. This is by Philips. You can use a CT guided in conventional ways. Now you can use biplane angiography. By combo CT, you can have a picture almost similar to the CT, and you can make a guide. This is green line. Then you can go through it on the 2D images. When your needle is away from it, you will have an alarm, and then reassess. Actually, it doesn't go only in 2D, no 3D, during actual working. The Embo Assistant, this is by General Electric. It's about, this is, you can detect more, 50% more HC feeders than usual DSA. Depend mainly on the density of the contrast and the flow of the contrast and timing of the flow to appear. This is by Siemens. They can actually measure the volume of the aneurysm, only calculation. Just you click a button, and then the volume appear, so you can have an idea about the size of coils that you need to occlude this aneurysm. Another technique also by Siemens is simulate the stent. When you have an aneurysm, you can click, just one click, give you the virtual stent and the measurement of the stent and the size of the stent. This will decrease the error and decrease, you don't need a very experienced person. Also, image fusion. This is done by Philips. It combined the cone beam CT and the 3D on the regular 2D DSA to guide you to embolize your, during the operation. Augmented reality, this is the last one. Augmented reality actually done by Philips, and this is a prototype, not commercially available till now. They are in collaboration with Microsoft HoloLens to make a hologrammatic interaction. I will let you with the video.
Therapy is modern-day surgery without the incision. We're navigating tiny instruments through the body through incisions no larger than a pencil point. We're relying solely on X-ray images or medical imagery to guide us. So that means we are always looking at a screen of data.
With HoloLens, we can take it to the next level. We are a leader in image-guided therapy. And with Azurion, we created an industry-leading platform that customers really love. What's really cool about it is we've leveraged novel touchscreen technology to create a very powerful working spot for the physician. Our ultimate goal is to help doctors do procedures better, to help them innovate the procedure. With HoloLens, we can create a completely different experience, a working domain which is really tailored around the needs of the physician.
For complex procedures, physicians need to go from one screen to the other really rapidly. We can now get these screens to come in just by voice recognition, by eye tracking. This is all about efficiency. If patients are being treated and the procedure can be shortened, it's very beneficial for the patient.
At Philips, we strongly believe that technology is not the goal, technology should be the enabler. What we want is that the physician can just concentrate on the procedure and the patient, get them home faster and healthier. This partnership between Philips and Microsoft can have our users experience something completely new, something almost mind-blowing, something that they didn't think was possible, and help them improve care. That's a breakthrough. That's a complete game changer.
And this is a Novorad company, make an open site project. This is a lens, the physician can use it to synchronize the cuts of the older CT of the patient in his body. This is only a prototype, not commercially available, but I think it will come in a few years. And the post-procedure, it only depends on the follow-up patients. You can order a create in the patient and he'll follow up. If there is any increase in the create, he will alarm you. You can order a CT chest to detect the lung pneumothorax post-biopsy, and also long-term follow-up of the patient. The limitation, the small IR data and small training. The AI mainly depend on the data. The more the data, he can be well trained. Also standardization of IR practice. As the IR practice mainly a state of art, more than solid steps. Also variation in the anatomy and the pathology. This make hard for the AI to repeat the procedure every time. Also disruption of responsibility between the physician and their patient. Thanks.
Thank you, Dr. Mohamad. Now we shift to the next talk. May I call